you did that, they're probably like, oh, well, thank you. Yeah.
Thank you for inviting me to this presentation about the flu. And my name is Jorge Mera. I'm the infectious disease physician at Cherokee Nation. I'm based at Hastings, but I go around the clinics to try to deal with the infectious disease problems that come up. Can everybody hear me? Okay. So I'm not sure what you want to know about the flu, but I put together a small 20-minute presentation of an overview of the influenza virus, what it causes, and after that I have time, and if you want and you have time, I'd be happy to answer all the questions I can, and I'll listen to all the questions, and I hope I can answer most of them, and I'll do my best. I think I'm going to use this as, let me see if this is moving. Yeah, okay. So the outline of the presentation today, I'm going to address what is the flu, a little bit about epidemiology. Sometimes it gets confusing when we hear all these numbers, H1N1, H2N3, epidemic, pandemic, and see if I can at least clarify some of those issues. You know, what are the main symptoms and complications of the flu? How do we diagnose it? What do you expect to receive when you go to a medical care provider and you have symptoms compatible with the flu? What's going on right now with the flu? I'll give you a little bit of a statistics in Oklahoma and some of the vaccination rates we've had at Cherokee Nation. What can be done to prevent it, and a little bit about the treatment. So the definition of the flu, and I've outlined the critical parts of the definition, is it's a seasonal, contagious, acute respiratory illness caused by influenza viruses that infect the nose, throat, and the lung. And about this definition is important. Seasonal is because we usually have it in the fall and on the winter. There can be flu all year round sporadically. We usually don't pick it up because all the laboratories that are called sentinel laboratories that are detecting when the epidemic comes start working around the fall, around September, October. It is acute. It's not a chronic condition. It comes and goes. You will survive most likely. A few will die. And it's caused by a specific type of viruses called the influenza viruses. And that's very important to distinguish from other respiratory illnesses because we have many viruses that cause respiratory infections, but the flu virus has some peculiarities. We can prevent it with a vaccine. We have medications to treat it, and it can cause mortality. So normally in an epidemic or when you have your seasonal flu, 1 out of 10 adults get infected, 1 out of 3 children get infected, and it causes in the United States an estimated death toll of around 10 to 40,000 people. Now this is important to highlight, the 1 out of 10, because when I'm trying to convince my patients to get the flu vaccine, one of the answers I encounter commonly is, I never get the flu, or I rarely get the flu. And they're not lying, they're telling the truth. They'll get it, statistically speaking, once every 10 years. Because the chance of getting the flu in a non-pandemic situation is only 1 out of 10. But if you're the unlucky one this year to get the flu and you have not taken the precautions of vaccination, you are at risk of death or of complications. Children have a higher burden of the disease, basically because they have been around not as much as we have, so they have not been exposed to viruses and vaccines as much, and they have less immunity than adults have. Another important thing to say about children is that the epidemics or the seasonal flu usually, I would risk to say almost always, start in children. And when the wave of the infection goes, the first sign you see in a community is school absenteeism. The kids get sick, they stop going to school, then the adult gets sick, then the elderly get sick, and then we see patients coming in the hospital with complications. So a little bit about the flu virus itself. This is just a cartoon of the flu virus, and there are several flu viruses, but there are 2 that are clinically relevant. They're important. And we call them type A and type B viruses. The type A viruses infects humans and animals, and the type B only infects humans. And this is very important, and I'll explain why in the next few slides. So this virus has surface proteins that are called hemagglutinin and neuraminidase. If you can notice, I highlighted the H and the N, because when you read in the paper or when you look at the news or in a scientific journal and you see we have an epidemic of an H3N2 or H1N1 or H5N1, whatever it is, this is the H and the N they're talking about, is the proteins on the surface of the virus. These proteins are very relevant for several reasons. And I'll show you on the next slide those reasons. So the type A viruses are the most important ones because they're most frequent. They can cause severe disease, including death. They are the cause of epidemics and pandemics. And they have genetic variation. That means that every year there might be a little bit different. And once in a while, every 2 or 3 decades, they're completely different. And that's when they cause pandemics. Type V viruses are milder in the disease they cause. They cause only epidemics. They do not cause pandemics. And they are very genetically stable. And that's the reason they don't cause pandemics. So what is the role of the H, of the hemagglutinin? The hemagglutinin is one of those proteins in the surface of the virus, and it's the responsible one for the virus to attach to the respiratory tract. So when you inhale the virus, you get infected, the virus goes in, and through that hemagglutinin, it attaches, it's like a hook or an anchor, to the respiratory cell. This is the reason why we are resistant to many of the avian flu viruses, because the hemagglutinin that the avian flu viruses have are not specific enough to attach to our respiratory tract. Unfortunately, some are, and that's when we read in the papers there's an outbreak of avian flu in certain countries or certain regions of the world. It's because a virus turned out that had that hemagglutinin that could infect a human. So the virus, this in red here on the cartoon, that's the respiratory cell. So here in green you see the virus. So the virus attaches through the hemagglutinin, this little protein here, and it gets engulfed by the respiratory cell, and then it starts replicating inside the respiratory cell. And after a few hours or days, the new viruses start budding out of the cell. So the H on hemagglutinin is the one that promotes the infection. Also, when we vaccinate people, what we generate is antibodies against this hemagglutinin, against the H. What is the role of the neuraminidase, or the N of a component of the virus? Well, here's the virus budding out of the infected cell, and it's like it's still hooked to the cell. It can't be released. That N, or neuraminidase, it's an enzyme that acts as a scissor, cuts that hook loose, and the virus can jump and go in and infect the neighboring cells. This is where our antivirals work. When you get Tamiflu or Relenza as antivirals, they inhibit this N, the neuraminidase. So what happens is that you get infected with the virus, and that's why you show up to your doctor with fever or whatever symptom you have, and the virus are replicating. They have infected already some cells. That's why you feel bad. They're trying to infect other cells, and if your provider acts quickly enough and gives you the medication and you take it fast enough, it will prevent that virus from spreading through the rest of your respiratory tract. That is why it's very important to act fast, because if you wait 48 hours, or more than 36 to 48 hours, the virus has already infected all your respiratory tract, and the medications in that situation is kind of useless.
Is it likely if you have your flu shot?
I'm sorry?
Is it likely if you already have a flu shot?
To have the flu? Yes, you can have the flu, and that's a great question, and I will explain a little bit more further, because
Does it cover A and B? Like
yes. Yeah, the shot is designed with 3 types of viruses, 2 A viruses and 1 B viruses, and in a minute I'll tell you how that's done. And so we have to be lucky enough that the circulating virus is the virus that's in the vaccine. This year, for example, 91% of the flu viruses that are in the community are incorporated in the vaccine. So it is a good vaccine this year. It's not an excellent vaccine, but it's a good vaccine. That's a very important point.
Thank you.
Okay, this cartoon kind of shows what I've just said. This is the virus with the surface proteins. It gets into the cell. It hooks up by the hemagglutinin, it replicates, and then it spreads out millions of viruses to other cells, infects the other cells, until all the respiratory tract is infected, and then it takes a while for you to recover and get your cells back as they were before the infection. Okay, in this cartoon I want to explain why the virus changes sometimes drastically, and we have a pandemic situation which we almost had a couple of years ago. So flu viruses not only infect, type A flu viruses, not only infect humans, but they can infect birds and other animals. So when a flu virus infects a human, it will replicate in a human. When it infects a bird, it will replicate only in the bird. But pigs and other animals can be infected by avian and by human viruses. So let's say you're a pig farmer and you got your pigs, or maybe you're not a farmer, but you have a pig in your home for whatever reason. I have heard they're very friendly, very cute. So imagine if you got the flu and you infect your pig, and there's some birds around who have the flu, a different flu, it's an avian flu, and they infect the pig. These viruses reassort and rearrange inside the pig, and a new virus might come out that if the hemagglutinin is specific enough to infect a human, it will infect a human being. What's happened in that situation? That now we have a completely new virus in the community, that if it can be transmitted effectively between humans, it will start a new epidemic and probably a pandemic, because nobody has immunity against that virus. I don't know if you've heard in the news in the last few months, there's a H3N2 variant virus, which came from the pig. It's a new virus, but apparently the transmission is good from the pig to the human, but not good from human to human. So the people who have gotten infected, it's because they're in contact with pigs. But they don't infect their co-human cohabitants in their family or colleagues, because it can't jump very well from human to human. Thank God. So what are the signs and symptoms of the flu? And you know this better than anybody, because everybody once in a while has gotten the flu. But the main symptoms are fever or chills, cough, sore throat. You can have a runny nose. Muscle and body aches can be very severe. Headaches can be very severe, especially retroocular pain. I mean, you feel like you got a real severe pain behind your eyes. Fatigue, and in children, vomiting and diarrhea is very common. Sometimes it's a misdiagnosis if the kid only comes to the emergency room or to their provider with vomiting and diarrhea, because that is a common symptom in children. So here we have that the virus replicates in your upper airways, that's your nose, your throat, but it also replicates in your lower airways, which is the lungs. And if you're lucky enough, it'll take a few days until it finishes its replication. You'll be sick for a few days, maybe a week, and then you'll get better. But some people are not so lucky, and they get complications. And what happens is that the bacteria that are around take advantage of that respiratory tract that is inflamed, that is denuded. I mean, the cells are not there, and they invade our respiratory tract, and they cause sinusitis, otitis, bronchitis, pneumonia, and this is a killer. When you get pneumonia after the flu, that's when you're at high risk of dying. If you have asthma or COPD, that can get exacerbated, and people can even die of that exacerbation. And rarely you see other types of problems like heart problems, severe muscle problems, and even central nervous system inflammation, and this can lead to death. So just to put it in perspective, I mean, what is the risk of someone dying from the flu? And the risk is 1 in 100 to 1,000 people if you're a smoker at age 40. So what is my risk of dying? If I'm 40 years old and I smoke, my risk is from 100 to 1 in 1,000 of dying of anything. How about if I get the flu? My risk of dying is 1,000 in 10,000, which is very similar to a motor vehicle accident death. Now, if I get leukemia or I get killed by someone, my risk of dying of those causes is 1 in 10,000 to 1 in 100,000. And going down the list, the risk of me being killed by lightning is 1 in a million. So this gives you an idea. I mean, this is more frequent than getting killed by lightning, getting hit by a train, getting murdered, getting leukemia. a little bit less frequent than dying by smoking. But it is an important cause of death. Not everybody has the same risk of dying from the flu. There are people, because of their medical conditions, that have a much higher risk. The list is very long, but just for you to have an idea, if you have any chronic medical condition, you're at higher risk. If you have heart disease, if you have diabetes, if you have COPD, if you have any type of cancer that it's on treatment. If you're older than 65 years old, you have higher risk of dying. If you're a pregnant female, you have a higher risk of dying. There was a big toll on deaths and pregnancies in the 2009 H1N1 pandemic. So there are risk factors that put you in a higher risk of dying. But having said that, unfortunately, in my 20 years of doing infectious diseases, I've seen more than a handful young, healthy adolescents and adults die of the flu without any underlying condition, unfortunately. And it's a very sad situation. Another important thing that you'd have to know is that the flu, it's not the cold. The flu, it's not all the other respiratory viruses. And there are some symptoms that can give you a hint. So when you have a cold that's usually caused by another set of viruses, including rhinovirus, you'll have very low-grade fever, if any at all. Headache is rare. General muscle ache is mild or rare or not at all. What is common is for you to have a runny nose, and it's common for you to sneeze, and it's common to have a sore throat. Now, you won't die of the cold, and most people will not die from this cold. There's no vaccine for the cold, and there's no specific treatment for the cold. So if you're at your home right now, and you develop these symptoms without fever, without muscle aches, without all the symptoms I've mentioned there, you probably have the cold, and you probably don't need to see your medical provider unless you're worried about something in particular. Now, if you have all these other symptoms, like we mentioned before, high fever, headache, severe myalgias, in this time of year, most likely diagnosis is you have the flu. And you should not go to work, but you should contact your medical provider to see if you need to be treated with an antiviral or not. And do that fast, because if you get sick on Friday and you'll say, okay, I'll go Monday to the doctor. If you have the flu and you needed an antiviral, it'd probably be too late to give it to you. So how is it spread? I think this is a pretty graphic picture. We don't see this when someone coughs, but this is what really happens. And once we cough, we spread all these droplets up to 6 feet away from us. And that's why in the hospital, when we think a patient might have the flu or has the flu, we use a mask if we're going to be within 6 feet of that patient. So coughing, sneezing, and even talking. I don't know if you've noticed that sometimes you're talking to someone and suddenly you feel something in your eye and they're spitting on you. They're not doing that on purpose, but it does happen. That's the main way that you will get infected by the flu. Other ways are, for example, I'm touching this desk right now. If someone was here a few minutes ago who has the flu and sneezed on his hand and then touched the desk, and I'm touching the desk, and then suddenly I start, picking my teeth or something else that I shouldn't be picking, I'll get the flu. So that's why in those brochures that you will read and on the CDC recommendations, besides the vaccine, which is the most important way to prevent it, wash your hands frequently, especially when you're touching surfaces that other people touch. The other important thing about the contagiousness of the flu is that once you get the flu, the day before you develop symptoms, you are spreading the virus. The virus is already replicating in your respiratory tract, and if you sneeze or cough or talk, actually you won't be sneezing or coughing because you don't have any symptoms, you can spread it around. So once you have the symptoms, the day before you've been spreading the virus around. And it usually you spread the virus an average of 5 to 7 days after you caught the infection. So if today I get sick, I will be spreading the virus for the next week. That is very important for you to know, especially if you work in environments where there's a lot of people. Well, you shouldn't go back to work until you're not coughing or sneezing anymore. And if for whatever reason you have to go, you have to wear a mask to decrease the infections of your colleagues. Okay, so how do we get diagnosed with the flu? We have many types of tests. The ones that you will encounter when you go to the medical provider's office is what's called a rapid test. And we have it in Cherokee Nation Hastings has it, and I'm sure most of our clinics have it. And the test has a sensitivity of 60 to 70%. What does this mean? That means that if the test is positive, you probably have the flu. But if the test is negative, there's still 30 to 40% chances that you have the flu and the test is negative. Because it's an okay test, but it's not a great test. The great tests, which are the ones below, the molecular testing and the cultures, those are done at the health departments, research laboratories, in very specific labs. We can order them, but they're time-consuming. They take time to get the results back, and they're very expensive. So we don't use them yet on our routine clinical practice. Now, the question is, do I need a flu test when I go to my doctor during flu season and I have typical flu symptoms? And the answer is probably no, because your doctor's judgment is probably as good as the test is. And there's many studies that have proven this. So if you're in the middle of a flu epidemic like we are right now, and you come in with fever, cough, and myalgias, there's 70% chance you have the flu. That's the same thing as the test is telling me. So the doctor can decide what to do without having a flu test. Now, if the doctor is going to decide what to do based on the flu test results, that's a different story, and he can order it. Meaning, if it's positive, he's going to treat you, and if it's negative, he's not. Okay, then the test is worthwhile ordering. But if he's going to treat you anyway, no matter what the result is, it's a waste of time and money to get the test done. So don't be disappointed if you don't get tested when you go to the clinic, as long as the doctor gives you a good explanation why he's not testing you. And the explanation could be because I'm going to treat you anyways, or because even if you had it, we will not treat you because it's been more than 3 days since you have had the symptoms. And I'm mentioning this because many of my patients come up and said, oh, I had the flu 2 weeks ago, went to the doctor, and he didn't test me. And, well, he didn't really need to test you. Testing is more important in non-epidemic situations when we're not sure if it's the flu or if it's not the flu. So what's going on with the flu in our country? Well, everything that you see in gray, that's widespread. The only yellow states are the ones who have the flu, but it's not widespread. Now, this is last week's map. I pulled today's map, and you'll find this. That means that California is not safe. They got it too. And Tennessee probably is just going down, because if you look the week before, Tennessee had widespread flu infection. And now probably in their state, the epidemic is calming down a little bit, so they're having less flu cases. If I would show you the map a few months ago, everything would be white. There was no flu activity, and this is available online. You can go to FluView and check what the status is. So what's going on in our state, in Oklahoma? Okay, so ILI stands for influenza-like illness or flu-like illness. Anybody who comes with cough and fever is defined to have an ILI. So right now, 8.4% of patients that are coming in to be seen have ILIs. And that's above our baseline, which is 3.5%, and that tells you that we're probably in an epidemic situation. We would expect 4.5% of the patients to have this, and we have 8% of the patients having this. Now, 21% of the flu tests done in the clinics have been, in the Sentinel clinics, have been positive for the flu. That means that 1 out of 5 have a confirmed flu. But there's probably a few more that have the flu and the test was not positive. Now, the important thing is that 86%, or most of the flu virus that's circulating, is influenza A. 9% is influenza B. All of the influenza A that's circulating, it's in the vaccine that was given this year. And 2/3 of the influenza B is in the vaccine that was given this year. So just to give you an idea, in the last week we've had 100 in Oklahoma, 100 confirmed hospitalizations for the flu, compared to 500 since the flu started in September. So our last week was really bad. I mean, we had 20% of all admissions happen last week compared to all the admissions that happened in the last few months. And there has been 8 deaths reported. Now, this is an underestimate because these are confirmed flu cases. Many patients come in with a pneumonia, and if the doctor, and they die, and if the doctor does not put that he's dying because of the flu or that the cause of death was the pneumonia, this will not be captured by the data collection. So this is the minimum number. This chart just represents the same than the last chart, just in a graph form. So you see the different months of last year, and then when we go into January, and then the hospitalizations and death climbed up dramatically. And probably, I mean, I can't predict this, they're going to start slowing down soon, hopefully, but we still might have a lot of activity for the next few weeks. Okay, so how can we prevent the flu? Yearly vaccination. And the answer is yearly vaccination, yearly vaccination, and yearly vaccination. That's the most important way to prevent it. You can also add to this washing your hands regularly, avoiding touching your eyes, mouth, and nose, especially if you haven't washed your hands previously. And have good etiquette when you sneeze or cough. Don't only sneeze or cough on your hand, do it on your arm like this, because your hands are touching other things later and you can contaminate other surfaces. And teach your children how to do this. Actually, kids do it a lot better than adults. I've seen the kids do it, and I don't know if in school they're teaching them, but they do it great. But yet I see some adults that don't do it, and they even cough on your face sometimes. And disinfect the surfaces that you work in your work area frequently. Okay, so the flu vaccine, you'll see a bunch of information out there because now we have a lot of types of flu vaccine. The most important thing is that all flu vaccines have the same viruses. The 2A viruses and the B viruses are all in the same flu vaccine. So there's the regular intramuscular shot. That's the one we're most used to, the one we've been getting for the last few years. So it's a shot on your deltoid area. And everybody older than 6 months of age can get it. Now we have a new high-dose intramuscular vaccine. The CDC has recommended it for people greater than 65 years old. This vaccine, the advantages, has a very high dose of the virus. So in that group of patients that the immune response to the vaccine might be a little bit slower, it is better with this vaccine. The side effects are a little bit higher too, because you're getting more antigen injected into your muscles, and maybe you'll have a little bit more of pain, maybe you'll have a little bit of fever the next day, but it's a fairly safe vaccine just as the other ones. Then we have an intradermal vaccine, and this was designed for patients who are scared of big needles, because the needle here is a very tiny needle. It goes into your skin, it doesn't go into your muscle. It has less viruses, less antigen in the vaccine. And probably the side effects are a little bit less because the antigen concentration is less. And then we have a nasal spray flu vaccine, which is a live attenuated vaccine. All of the above shots that I've mentioned are called split virus vaccines. That means you don't get, the virus is dead, you don't get the whole virus, you get parts of the virus. And on the nasal vaccine, it's an attenuated live virus. And that can only be given to people 2 to 49 years old that are completely healthy. The other vaccines you can give to anybody that has other diseases like diabetes, COPD, heart disease, etc. But the live attenuated is only for healthy people. The good news is that recently, a few days ago actually, the FDA approved a new vaccine, which is a novelty because all these vaccines are made in eggs. So if you're allergic to eggs, you might not be able to have one of these vaccines. This vaccine, the new one, is genetically engineered. It's actually made by another virus. It's a different virus, and it produces the hemagglutinin. That H that I explained in the previous slides, it directly produces that, and that's what's going to be injected. The advantage is that we can probably will be able to count with mass production of vaccines if needed. Let's say we have a pandemic situation and we need to produce a lot of vaccine. You can probably do it a lot faster on that with that setting. And the other issue is that it's not produced in eggs. So if you had an egg allergy, that won't be a problem anymore. So how do we, not me, but how does the FDA decide what viruses goes into the vaccine? Well, the WHO, the World Health Organization, every year meets, and they have labs all over the world, and they're testing all the viruses that are circulating. And they choose the viruses that are circulating the most to say these are probably the ones that are going to hit us on the next epidemic, on the next season of flu. And they make a recommendation, and all the pharmaceutical companies that produce the vaccine follow those recommendations. And the FDA meets, and if they agree with the WHO, which they usually do, they incorporate the viruses. So this year's viruses are the ones you have listed there. It's 2A viruses, One is the H1N1, the one that we had in 2009, and the other one is the H3N2, and then a B virus. So the virus that's predominantly out there in this season is the H3N2 virus. There's very little or hardly at all H1N1, and there's quite a bit of B, maybe 9% or 8%, and 2/3 of the B that's circulating is this one, but 1/3 of the B that's circulating, it's not in the vaccine. So that's why the vaccine is 91% protective. Has 91% of the virus circulating. I'm going too fast, please stop me. So, in summary, this year's vaccine has a protection rate of 63%. Although 91% of the viruses are in the vaccine, not everybody responds to the vaccine. Okay, not everybody mounts a good immune response. So that's why the protection rate is 63%, and that is considered good. Now, the most important thing you need to know about the vaccine is that although it won't protect 100% of the people who get it, it will decrease their chance of dying. So let's say I get the vaccine, I can get the flu. As a matter of fact, last year I got the flu and I was vaccinated. I had this interesting situation, and when this doctor just asked me to see a patient, and he threw the patient in my room, and the first thing the patient did, instead of shaking my hand, was cough on my face, and he had the flu. So I said, oh, I hope the vaccine works, and it didn't. 2 days later, I was with the flu. But I'm still here giving the talk, so that means I didn't die. My flu symptoms were not that as bad as they were many years ago when I got the flu, so I think I did get some protection from the vaccine. So, because that's another thing people say, oh, I got the vaccine before and I've gotten the flu, and it's true. But the chances of you dying from the flu are much less if you're vaccinated than if you're not. Okay, so how are we doing at Cherokee Nation with vaccination rates? And I've listed the different clinics and places, and the percent here, in this column here, is the total vaccination rate, and on the right, the vaccination rate in the patients who are 65 years or older. Why did I separate this? Because the ones who are going to have a greater mortality from the flu are the group on the right. And those are the ones that we want to protect we want to protect everybody. But if we want to concentrate on someone, is that group or the patients who have chronic conditions. So we're not doing bad, but we can do a lot better. Roughly the rate goes between 56 and 70% of vaccination rates in the older population, and around 20 to 40% in the younger population. So if we want the next epidemics to be milder on us, we have to increase our vaccination rates. And that depends on everybody. It depends on us as medical providers, and depends on the patients wanting the vaccine and being able to get the vaccine. So I hope we can coordinate a bigger plan for next year to increase these rates. Okay, now let's say you got the flu. You got your vaccine, but you were unlucky like I was last year, or you forgot to get it, or you didn't want to get it, or you really couldn't get it because you were allergic to eggs or something like that. So we do have treatment, and you've heard of these two medications, Tamiflu and Relenza. The one we use the most is Tamiflu. This is an oral, it's a pill that you take. And this inhibits the neuraminidase, that protein on the surface of the virus that acts as a scissor and cuts the virus loose from the cell that has infected. So it inhibits that. So it decreases your symptoms by 1.3 days. Let's say you were going to be sick for 4 days. Now you're going to be sick for 2.5 days or so. But you have to give it quick. You have to give it within 48 hours, and preferably as soon as you know you have the flu, you have to start taking the medication. That's when it's going to have the best effects. The benefits, besides decreasing the duration of your symptoms, is that it will decrease the complications. Children who take it have less otitis media. Adults who take it have less incidence of pneumonia. And there's also some studies that it decreases the death rate. So basically you have the flu virus here, it infects the cell. It wants to spread, but this is magnified in this cartoon here. And the neuraminidase, which is this protein on the surface of the virus, which cuts this loose, is inhibited by the Tamiflu or the Relenza. That's where the drug acts. So the virus is kind of stuck home. You can't let it you don't let it out of your house. It's in there. Just to answer some questions were already done. A common question is, why do I need to get vaccinated every year? Because the virus that circulates every year is a little bit different than the year before. Sometimes it's the same, but it has changed a little bit, and that's why the flu vaccines change their components on a yearly basis. Does the influenza vaccine cause the flu? And the answer is no, because you're not getting a live, in all the shots, you're not getting a live virus. It's a particle, it's a part of a virus. So it cannot replicate, it cannot cause the flu. The live attenuated influenza vaccine potentially could cause it, but it really doesn't. Many studies have been done, and it hasn't shown to cause the flu. It can be spread to another person, but the virus is only viable in the nose where the temperature is lower. Can I still get the flu and vaccinated? And I've answered that. Yes, you can, and I have lived personally through this. But your chances of dying are less. If I have already had the flu, should I still get vaccinated? And the answer is, what do you think? Yes or no? Who votes for yes? Good. You're right. Because there's several viruses going around. And we don't know if you're not going to get the other one that's circulating. So if you have the flu, you can get the flu vaccine. So what can we do better next year? I think we can vaccinate more. And that's an effort of the medical system and the community and the leaders and the people, that we all get together and make a good plan to vaccinate as many citizens as we can. And thank you for your attention. Is there any questions? Yes.
How long is the flu? If I touch a table and somebody else touches the table, how long does that actually live on the table?
In a surface that has not been disinfected, it will probably live about a day or a day and a half. So that's why you should clean it every day, your workstation or your work area. Yes. And the incubation period is from 1 to 4 days. Any other questions? How many of you got the flu vaccine this year? Good. So I shouldn't have been talking to you. Okay. Well, if there's no more... Yes. Is there any question?
I think it's the people that didn't have the flu shot.
Yeah, they're probably home with the flu. That's why they're not here. Yes.
Is there a rule of thumb a school goes by before they close down that school if so many students have had the flu? Or is that just something they just kind of...
Well, if there is I would say this. I don't think there is a rule of thumb. I think you have to evaluate each situation individually. And usually the health department does that. But if you're having let's say that most of the population of that school have not gotten the vaccine, or the virus that's circulating is not in the vaccine, and you're having more than 20 or 30% of the kids getting infected, that may be a good reason to shut down that school for a few days until things come down. Now, I don't have I'm not a public health official, so I don't have in the top of my head what number they exactly use to shut it down. But I have been involved in those situations in the different communities I have worked, and it's always a big discussion. And there's not a straight number that I'm aware of, or else it would be easy to shut it down and to open it or not shut it down. But if you think that most of the kids will get infected and most have not been protected, that could be a good reason to shut it down.
Can you explain, telling you, so you're fighting the virus with the virus? Is that how it works?
The vaccine, you mean? Well, what you do is, you know that the virus needs to infect your cells for it to replicate. And the way it infects your cells is through that protein in the surface called the hemagglutinin. It attaches to your cells and it buds in your cell. So when you're giving the vaccine, you're generating antibodies that hit that protein on the virus. So it's blocking the protein. It's blocking that hook that attaches the virus to the cell. So that's the way that you are acquiring protection. Now, why is this vaccine not 95% effective? Even, let's say that the virus that it's circulating is the one that you have in the vaccine. Because the vaccines act from the inside to the outside. I mean, they produce the antibodies in your blood, and this virus is attacking the surface of your cell. So you would have to have antibodies in the surface of your cell to really block all the virus coming in. And you do get some of that with the vaccine, but it's not like if the cells were producing the antibody. That's why it's not a perfect vaccine. But that's the way it acts. So you stimulate your antibody production for it to block the virus when it's trying to hit your respiratory tract. Now, that immunity is not long-lasting. It starts going down probably in 6 or 8 months. And that's why, even if the same virus is circulating next year, you need to boost your immunity with the vaccine.
One more question.
Sure.
Why is the flu only like in the winter?
That's a great question. The scientific answer is we don't know, but there are some hypotheses. Why is the flu seasonal, and why we have it in the winter? Why don't we have it all year round? Well, there is flu all year round, but very, very low levels of sporadic cases in the summertime, etc. And one of the hypotheses is that, well, people are closer together during the winter. So it's a better situation for transmission because you're not outside, you're closed inside doors. So it's more effective to transmit respiratory virus that way. The other is that with the traveling, you can get a virus might not be in the community, but we move around so much over the world. You catch a plane. Actually, when I got the flu last year, I had to catch a plane to go to Argentina the next day. So I was from the winter taking the flu virus back to Argentina in the summer. So some Argentinians might not have been happy of that, me coming there. But it is really not known. When you read the literature, they will give you many hypotheses, but it's really not known. Mm-hmm. Any other questions?
If I have a flu shot, what's the percentage that I will get flu during the season?
Okay, so you have a 10% chance, just a random 10% chance of getting the flu, even if you didn't get the flu shot. So if you got the flu shot, you're decreasing that percentage to probably a 2% or 1% chance of getting it. Because the vaccine is not 100% protective. If it was 100% protective, it would go down to 0%. But it protects you 60-70% of the times, so you'll still have probably a 2%, 1 to 2% chance of acquiring the flu, even if you're vaccinated, statistically speaking. But some people, that didn't get the shot will not get the flu, and that's their argument of not getting the shot. And they were just lucky. I mean, they just played the right number on the roulette, and they were lucky. So this is all a matter of probabilities, of chances. It's like, what are the chances of getting killed in your car if you don't put your seatbelt on? Well, if you don't have an accident that day, it's 0. And you didn't wear your seatbelt, and you can say, oh, why should I wear seatbelts? I came to work today and I didn't die. But if you happen to have an accident, making the comparison, if you happen to run into the flu virus, then you're more protected if you have the vaccine than if you don't have the vaccine. You're more protected if you were wearing your seatbelt while you had the accident in the car than if you were not wearing your seatbelt. And it's just a matter of probabilities. And we take risks every day of our lives. People sometimes, with good reasons, are afraid of vaccines or afraid of medicines. They're as safe as we can make them. They're not perfect. But having said that, I ask my patients very often, when they don't want a vaccine, well, how did you get to my office today? Well, I drove. So you can't get killed driving. I mean, nobody dies in a car accident. Oh, yeah, they do. Well, but you still got into a car. So you took that risk because you evaluated the benefits and the risks. And you probably, drove, you stopped at the red lights, you used your seatbelt, you didn't speed up. So you were taking all the precautions to make that risky business as less risky as possible. And that's what we do with medications and with vaccines. We try to make the risk much lower, but of course it's not perfect. And it's a balance that you put every day, and you take a risk, and you take it if the benefits are greater than the ups are greater than the downs.
With Tamiflu, is there different levels of dosage, just like all other medicines?
There are different levels depending if you're a child or if you're an adult. If you're an adult and if you have normal renal function, it's the same dose for everybody. So if your kidneys are working well, and it's 75 milligrams twice a day for treatment. Now, there's also an indication in some situations for prophylaxis. Let's say I ran into someone who has the flu. I did not get the vaccine for whatever reason, and I'm scared that I might get the flu, so we can give that patient, if he's at high risk of complications, Tamiflu once a day for 7 to 10 days to decrease his risk of getting infected. And that the dose goes by half. It's only 1 pill a day. And the other one that we have that we don't use, it's not used as often, is the inhaled one. The inhaled one has a little bit more contraindications. You can't use it in people who have asthma or problems with their airways, but it's also a good vaccine. A good drug, antiviral. Yes?
So what do you give people that don't, they miss the time frame, they can't take the Tamiflu? What do you suggest to give them to?
Okay, the treatment is symptomatic. There's one exception to what I just said. There's always exceptions to the rules. If you're so sick that you had to be admitted to the hospital, the CDC recommends using Tamiflu even if you started with the flu symptoms more than 2 days ago. Okay, so in that situation, we'll give them the antiviral anyways. But let's say you just have the symptoms of the flu and you don't have any complications. The treatment is symptomatic. So treatment for fever, you can use Tylenol or you can use ibuprofen, keep well hydrated, and so just symptomatic treatment. And be aware that complications might come. So if 5 days later that you should be getting better, suddenly you start getting worse, you need to see your doctor immediately, because now you might have a complication. You might have a pneumonia, or you might have a sinusitis, or in a child they might have an otitis. So if you can't take Tamiflu, just be at home. Try avoid meeting other people so you don't spread it to them. Use the etiquette techniques of coughing and sneezing. Use a mask if you're going to be close to someone who has not gotten the flu. And just have a low threshold to call your medical provider if you think that instead of getting better as the days go by, you start getting worse. Especially if you have an underlying medical condition like COPD, diabetes, heart failure, any cancer that's active, your immune suppressive medication for whatever reason. Yes?
Does that include, I guess, thyroid, do the radioactive iodine therapy for thyroid?
I don't think that would be, that usually is not an immune suppressive state. So I don't think that falls into the high rates of complications if you have only that condition. Now, if you have metastatic disease, that's a different story. I mean, your cancer is active and you do fall in the chronic condition category. But if you had a tumor that was surgically removed and you're getting the radioiodine just to suppress, any other tumor cells that might be out there, I don't think that puts you in a big immune suppression state. I would have to review and check on the list. The list is very long. It's like your telephone book. You start looking. But I don't think I've seen that one on the list. And just by thinking of what the situation is, it's not a dose of irradiation that is going to harm your bone marrow in a way that will put you in a bad position.
Is there a correlation between the flu and race?
There is a correlation between, well, that's a great point that I was going to put in my slide. There is a correlation. For example, being a Native American puts you in a higher risk of complications for the flu. Now, is there a correlation between acquiring the flu and race? Not that I'm aware of, but yes, of complications. When you look at the CDC recommendations of who should receive, for example, who should receive Tamiflu? Not everybody, there's not an absolute indication to give it to everybody who has a flu. So you give it to those persons who fit the window period, no less than 48 hours of infection, and who have an underlying condition that can put them at an increased risk of complications. On that list is Native Americans. I'm not sure where that data was obtained and what study. I haven't read the study that made the CDC put that recommendation, but it's there. So, yes, the answer is some races have higher risk of developing complications. As far as I know, I don't think there's races that have a higher frequency of acquiring it, as far as I know. But of complications, yes. So in theory, I was discussing this with my colleagues the other day, everybody in our nation should get Tamiflu if they're within the 48-hour window because they're Native Americans by definition. That's a great question. Anybody else? Well, thank you very much. And if you have any questions, you know where to find me. Thank you.